Hello students, today is the last session on the UVA. Today we are covering sympathetic ophthalmitis, endophthalmitis and panophthalmitis. So let's move on to the first the disease, sympathetic ophthalmitis. So what is this sympathetic ophthalmitis is there? So this occurs most of the time following the penetrating injuries. So the injured eye is called as exciting eye, where the patient has suffering with a penetrating injury. And after some time the other eye is also involved. So that time we call it as a sympathizing eye. Why other eye is also involved? This is because whenever there is a trauma, there will be exposure of this uveal tissue. It may be iris, it may be ciliary body, it may be the choroid. What happens? There will be some the reaction takes place because of this release of these pigments. So these allergens acts as the stimulating factors, and that causes uveitis in the other eye, that is sound eye. So when other eye is involved, that we call it as a sympathizing eye and sympathetic, hence the name sympathetic ophthalmitis. So whenever the allergic reaction it takes place, there will be aggregation of lymphocytes, plasma cells, epithelial cells and gain cells throughout the uveal tract. So there is the specific nature of this collection of nodules in the posterior part of the uvea. We call them as a Dellenfuchs nodules. And in retina you also see the inflammation of the vessels, that is peri. So this is how the Dellenfuchs nodules are seen in case of sympathetic ophthalmitis, where it is in a sound eye. So what are the clinical features of sympathetic ophthalmitis? The exciting eye, that is injured eye, obviously it shows some sort of uveitic features, maybe in the form of congestion, lacrimation, capes will be there, some sort of tenderness will be there. Whereas the other eyes, that is a sound eye or it is a sympathizing eye, the involvement may starts or the features may start 4 to 8 weeks of injury minimum, or it can be later also. So it occurs in two stages. One is prodromal stage and then one is fully developed stage. In prodromal stage, that is the initial stage, where the patient may feel some sort of photophobia and transient indistinctness to the near object because he is unable to see the near object clearly. Then on examination you may see the flare and cells in the posterior to the lens, that is retrolental flare you can see, and some fine capes you may see in the endothelium of cornea. And there will be mild ciliary congestion will be there, on touching some sort of tenderness will be there. Okay, on examination there you can see the vitreous haze and some amount of discoloring. And when it is not treated in time, it may lead to the advanced stage. So the complete involvement of the vitreous, and there is a severe inflammation of the other eye. So here what happens, the patient may lose both eyes because of this. One is injured eyes, anyways it is already damaged, and the sound eye is also affected. So we should be very cautious while treating the injury cases. We can't neglect, because we have to save or retain the other eye also. So the treatment should be very and proper treatment of the injured eye should be there. If it is exposed iris is there, you have to cut it and you have to start with the steroids immediately. Okay, and you have to suture the wound properly. Then all the adequate the proper antibiotics should be given. Okay, and the regular follow-up should be there every monthly, then later on 3 monthly, and once in a year, because at till at least a year you have to go for the follow-up, so that other eye is not involved. Okay. Then coming to the purulent uveitis, where there is a suppurative inflammation of the uveal tract. Okay, the purulence is because of mainly invasion of pyogenic organisms. So it may start with the interior, or it may start with the posterior. It may start with the both. Okay, there can be spillover. That is, it starts in the posterior and it spreads to the interior side, or it may start with the interior side, or it may extend to the posterior side. So the purulent uveitis may land up with endophthalmitis or panophthalmitis. What is this endophthalmitis and panophthalmitis? So what is this endophthalmitis is? So it is inflammation of inner structure of the eyeball. What are the inner structures of the eyeball? Is the uveal tissue, retina and the vitreous cavity. Okay. So there is a suppurative inflammation of all the structures is called as endophthalmitis. Okay. So here suppuration is involved both in anterior and posterior chamber. So what is the causes for this endophthalmitis? There are various organisms which enters the purulent organism which enters the eye. It may be bacteria, it may be fungus. Okay, so bacteria may be Staphylococcus, Streptococcus, Pseudomonas, Pneumococcus, fungus, Aspergillus fusarium and Candida. So how they enter into the eye? It may be exogenous infection, it may be endogenous, or it may be secondary infection. Exogenous mainly due to perforating injury, or after the surgeries, or after your perforated corneal ulcer, where there is a easily assessment of entry of organism directly into the eye. Endogenous is the infection is somewhere in the body, through the bloodstream it enters into the eye because of metastasis. Okay, or secondary infection, there is an infection somewhere near the eye and it spreads to the inner structures of the eye. Okay, and there is one more entity called as the sterile endophthalmitis. Here there is no organism, but there is a reaction, there is an inflammatory and a purulent reaction because of some reason. One is post-operative. So in post-operative what we use is intraocular lens. So these usually sterilized by your ETO or UV radiation. So that's why we clean with the saline before putting the oil, so that whatever the toxicity is there on the oil, it should be washed off clearly. So sometimes there can be a reaction to this chemical adhered to the oil or instruments even though. And there is one more entity, we call it as a TAS, that is toxic anterior segment syndrome. So the patient usually is present with you as a post-operative endophthalmitis only, but there is the severity is not much. Okay, flare will be there, of grade 4 cells will be there, but the loss of vision will be comparatively less. And post-traumatic sterile endophthalmitis because of the retained intraocular foreign body. What happens if any foreign body in the form of any copper or the metal, if it enters into the eye and if it remains in the eyeball, and that the toxins released by that foreign body may cause the suppurative inflammation. Then phacoanaphylactic endophthalmitis. Phacoanaphylactic endophthalmitis is the proteins that are released from the mature cataract acts as the toxins, and that leads to the suppurative inflammation. Or sometimes the intraocular tumor necrosis. The tumor cells which are present, they may also act as the toxins, and that causes endophthalmitis. Okay, so the most common is our bacterial endophthalmitis. So as I told you, the source of infection may be anywhere because of trauma, or it may be post-op, it may be the corneal ulcer. So whenever there is a corneal ulcer or before doing any surgery, we try to look for any foci of infection is there near around the eye. Okay, because it may further aggravates or it may act as a source of infection for the further inflammation. For example, if you are doing the surgery, so definitely you have to undergo the sac syringing to rule out any infection is there in the lacrimal system or not. If there is any blockage is there, so before doing cataract surgery, because you are opening the globe here, okay, so that causes easily access of organism to entry. To avoid that, do go for lacrimal surgery before your intraocular surgery. So if any lid pathology is there in the form of any stye is there, or any conjunctivitis is there, or any lid deformities are there, so before try to treat those things going for the surgery. Okay, even for the corneal ulcer also we go for lacrimal syringe, so that it is not acting as a source of infection of for the non-healing ulcer. Okay, so you have to treat the source of infection before any kind of surgeries, intraocular surgery you are going for. Or sometimes if the sterilization is not proper, okay, if there is a infection in unhygienic conditions, ideally we follow all the cleaning processes as such, to say hygienic conditions we follow, but sometimes it may leak. Okay, the onset may be acute within 1 and 7 days it may start, or in delayed endophthalmitis may start after week or a month. Okay, so what are the symptoms the patient comes to you? It's a severe ocular pain will be there, lot of redness will be there, lacrimation will be there, photophobia is there. The first thing is loss of vision. Here the patient, post-operative patient, immediately comes to you that he has a vision normally post-operatively, within a week he has lost his vision. So it is an emergency condition, it is an alert time, so where you have to take the intervention and examine properly. So on examination you may see the red and swollen edematous lids, conjunctivitis severely chemosed and congestion will be there, cornea shows edematous and cloudy, and if you any surgical mark is there, wound is there, it may show the yellow or necrotic. Anterior chamber shows hypopyon of various extent, it may be mild, may be there, or the AC is filled up with the hypopyon. Iris shows the edematous. If the cornea is some amount is clear and you could see through that, iris may show the edematous and muddy, and pupil also shows the yellow reflex, because the vitreous is also become the purulent. That's why the pupil also shows the yellowish reflex, and the vitreous, yes, it shows the yellowish mass, and IOP is definitely reduced in the initial stages, because the trabecular meshwork is blocked by your proteinaceous and the hypopyon. That's why the IOP is raised. Later on, it is reduced because of shedder. The next, what is the treatment for this endophthalmitis? The early diagnosis is treatment is very important, because you may lose the eye if it is treatment is not given in time. Okay, so the intravitreal antibiotics followed by the diagnostic tab. What is this? So ideally the combination of, you have to cover both gram negative and the gram positive organisms. So that's why you have to use the vancomycin and ceftazidime, or sometimes the amikacin in very minimal dose, near around 0.1 ml. You are taken into your tuberculin syringe and you are injecting into your vitreous directly. Followed by you are inspirating some amount of the vitreous to send it for the bacterial culture and the smear, so that you will come to know the specific organism causing this endophthalmitis. If it is a fungal, yes, again you have to go for the intravitreal injection of antifungal agents in the form of amphotericin. Then concentrated topically you have to start, followed by intravitreal injection in the form of fortified vancomycin, cefazolin, or tobramycin or amikacin combination. Then systemic also you have to continue with vancomycin 1 mg BD or ceftazidime 2 gram BD week at least. Here you can make out how the eye looks in endophthalmitis. Lids are showing a lot of edema, conjunctiva is completely congested, very fiery, the red you can see, and cornea is full of haziness. Okay, the structures are not seen in detail, and you can see the hypopyon, that is the pus in the anterior chamber. And on slit lamp we can make out the cells and the flares. Okay. If lot of easiness is there, posterior cells are not visible. So, and the next mode of treatment is the steroid therapy. Intravitreal injection of dexamethasone also preferred in case of severe inflammatory conditions, as well as the topical prednisolone 1% is given, followed by systemic steroids, oral corticosteroids 1 milligram per kg body weight, or IV is given first 24 hours. Okay, then supportive therapy in the form of sacroplegics, especially we prefer to use atropine, or you can use the 2% of home atropine TDS to keep the ciliary body calm. Then anti-glaucoma drugs to reduce the IOP. Then if it is not responding to this, yes, you have to, the final treatment is the vitrectomy, where the core vitrectomy is done, followed by the intravitreal injection. Then what is this panophthalmitis is? Here it is almost similar to the endophthalmitis, where the other structures are involved. In addition to that, the outer structures, the tenon is also involved. Okay, so it is the advanced form of the endophthalmitis if it is not treated in time. Again, the causative organism is the bacterial. Then, but symptoms are very severe compared to the endophthalmitis. Here, lot of headache will be there, complete loss of vision will be there, and some patient may feel fever and on examination very severe chemosis will be there, and you can make out the proptosed eye and limited ocular movements. That is the sign of panophthalmitis, where there are no ocular movements. Okay, then congestion, cloudy cornea, anterior chamber is full of hypopyon. Okay, then IOP is markedly raised. Then sometimes with the raised intraocular pressure, there may be a glue perforation may occur. So this infection may spread to the other adjacent nearby structures, causing the orbital cellulitis, or it spreads to the veins, causing the severe cavernous sinuses or meningitis and encephalitis. So you have the quick action for panophthalmitis in the form of evisceration. Evisceration is the only treatment in case of the panophthalmitis to prevent the spread of infection to your cranium and other structures of the eyeball. So followed by the and broad spectrum antibiotics and analgesics is also started. So this is how the treatment is done. So students, we are completing this UVR. Then if you have any doubts, you can contact through your Google classes queries. Please go through all the topics, because it is a very big and broad topic, as is to say. So we have learnt in a bit by bit. Okay, so the today's questionnaires is one is sympathetic ophthalmitis. Write a note on that, sympathetic ophthalmitis, and the second one is clinical features, signs and symptoms of endophthalmitis. Thank you.